Hey guys, this is Professor Rich, and this is the Module 2 VoiceOver PowerPoint covering HEENT, Integumentary, and Sensory. The content outline is very various, so we go through headaches, visual disorders, hearing disorders, and skin disorders. Headaches. Headaches are the result of the reaction of nociceptors, which are pain-sensitive nerve endings, to triggers, sending messages to the thalamus via the trigeminal nerve or cranial nerve 5. Primary headaches are not associated with underlying disease. So we have tension, cluster headaches, and migraines. So for tension headaches, these are episodic or chronic. The occurrence, so episodic occur 10 to 15 days of the month, and they last 30 minutes to several days. Chronic occur more than 15 days a month, and this is usually during a 3-month cycle. We want to treat the underlying cause. So underlying causes, this can be depression, anxiety. It could be poor posture, it could be arthritis related. So different things we could do, antidepressants, anti-anxiety counseling. For that poor posture, we could do physical therapy. Arthritis, we're going to be thinking anti-inflammatories, maybe corrective devices, NSAIDs, analgesics, maybe muscle relaxant. For our cluster headaches, so these are neurovascular headaches. The occurrence, usually it's the same time nearly every day for several weeks. There's usually periods of remission, which are often at night. These are severe, unrelenting, unilateral pain. It's usually in and around the eye. The peak pain is 5 to 10 minutes after onset, and they continue in intensity for 1 to 3 hours. For our migraine, so there's 4 phases. There's the premonitory phase. This is 24 hours before the headache develops. It's usually mood changes, fluid retention, maybe increased urine output, excessive or uncontrolled yawning, food cravings. There's something called an aura. This is prior to a migraine. An aura could be flashing lights or muscle weakness. It's basically the patient's warning sign like, hey, you're about to have a migraine. The headache phase. So the pain starts gradually and it builds in intensity. For some, there's a migraine without the headache pain. Then post-stromal phase. So many patients experience confusion and exhaustion for as long as 24 hours after the migraine. Treatments for this is going to be NSAIDs, analgesics, muscle relaxants, sedatives, and antidepressants. Often triptan medications are given. There is something called abortive therapy, and this is treating the signs and symptoms. Tylenol and caffeine are often used. Serotonin, which is a neurotransmitter, can cause vasoconstriction and lower the pain threshold. Again, with those triptan medications like sumatriptan, which is also known as Imitrex, those increase the level of serotonin and appear most beneficial during the moderate to severe migraine. Ergo-alkaloid medications such as Migranal, those bind to serotonin receptors on the nerve endings, decreasing the transmission of pain messages along the nerve fibers. So for prevention of these headaches, often Lamictal or lamotrigine is used. They might use gabapentin, also known as Neurontin. These increase the levels of many neurotransmitters and diminish pain impulses. They might use antihypertensive medications like beta blockers, for example, propranolol, calcium channel blockers like amlodipine. These prevent vasoconstriction or vasodilation in the cerebral blood vessels. Often, again, SSRIs and tricyclic antidepressants are used in prevention. We also want to ensure steady, regular meals as well as adequate fluid intake. We want to establish consistent sleep habits. Those can assist with relief and prevention of the headaches. Riboflavin or vitamin B2, magnesium, coenzyme Q10, those are also used in the relief and reduction of headaches. Moving on to vision. So the eyes are considered the window to the brain. 4 cranial nerves are involved with eye function, which this is reviewed from semester 5, but your cranial 2 is your optic, cranial 3 is ocular motor, 4 is your trochlear, and 6 is your abducens. So just briefly look over them. Again, this is semester 5 review. We can review further if needed. Inspection, so you're going to assess the symmetry of the structures. And then we're going to do vision testing. So our Snellen chart. This assesses visual acuity and distant vision. So you have your patient stand or your client stand 20 feet away from the chart. 20/20 vision is considered normal. A person with 20/40 vision standing 20 feet away from a vision chart sees what a normal person sees standing at 40. A person's considered legally blind if the best corrected visual acuity is 20 out of 200. The Ishihara chart, so this assesses color vision. I'm pretty sure we all had to do this at a physical at some point where you have those numbers in that circle and you have to say the different numbers that you see. Cardinal fields of gaze, so this assesses extraocular muscle function and your cranial nerves 3, 4, and 6. The patient's instructed to stand directly in front of the provider with the head held in a fixed position. The pen light is held approximately 12 inches in front of the patient's eyes. The patient's asked to follow the movement of the pen light with his or her eyes only. The pen light should be moved slowly in an orderly fashion, both laterally and medially. You're going to stop every so often to assess for nystagmus. Pupillary light reflex, so the patient should be instructed to stare straight ahead and the provider advances the light slowly from the side. The normal response would elicit a constriction of that pupil in a simultaneous constriction of the opposite pupil. And then we have our PERLA, which is pupils equal round, reactive to light and accommodation. So with our decreased vision or vision loss, we have safety risks. These patients are at safety, their risk for injury. So what can we do to help keep these patients safe? So I want you guys to think about that. If you have a patient that has blindness or they have trouble with their vision, how can we keep them safe? So some ideas is make sure their call bell's in reach, have the lights on or well lit, remove clutter, electrical cords. At home, they should get rid of decorative rugs. For you, when you're coming into the room, knock, announce yourself, and, you know, be aware of their vision loss. Visual loss related to opiate use. So drug use via injection with a non-sterile needle can result in a microbial bloodstream infection, which these can actually seed ocular infections. These can be bacterial, fungal, or viral. Despite treatment, nearly 50% of those affected will have no light perception, and the condition can lead to partial or even complete blindness. So patients with suspected endogenous endophthalmitis, that's the medical name, present with minimal clinical manifestations. They might have a red and painful eye, photophobia, floaters, reduced vision. Most often they present with unilateral clinical manifestations, so it's only on one side. And up to 1/3 of the cases will have bilateral involvement. Upon exam, symptomatic patients might have reduced visual acuity, conjunctival injection, corneal edema, and inflammation of the iris and vitreous parts of the eye. A key diagnostic finding associated with this is the presence of a white infiltrate originating in the choroid and sometimes erupting into the vitreous cavity. Specialized equipment and providers with specialization in eye disease examine the patient more extensively and make this diagnosis. Treatment needs to be initiated as soon as this is suspected and is often started even before a definitive diagnosis is made. The most common treatment begins with prompt intravitreal antibiotics. So this is going to be your eye drops, with hospitalization, infectious disease consult, and IV antibiotics. Cool compresses can be applied to the affected eye. This helps decrease inflammation. We should offer sunglasses. This can help with the bright light conditions. Assist with the healthcare provider examination by providing adequate lighting and equipment. Again, a definitive diagnosis and identification of the bacteria or fungus is key to effective treatment. So they need to get a culture and sensitivity. Safety considerations, again, this increases the risk of falls and injuries, so refer back to the last slide for more information. It is essential that the patients follow up with providers with scheduled appointments and closely monitor the healing process or any further changes in visual acuity. The outcome of endogenous endophthalmitis are variable and are generally dictated by the aggressiveness or the causative organism. In general, yeasts are associated with best visual outcomes, bacteria moderate, and molds with the worst. So patient compliance with prescribed treatments, especially antibiotic, antifungal, or antiviral therapies, is key to the treatment of this disorder. It is also important that the patient and family understands the connection between the IV drug use and the development of this disease. So this slide, we're just going to briefly go over eye drop admin. So you're going to wash your hands thoroughly, put on non-sterile gloves, verify the correct medication, time, number of drops. You're going to instruct the patient to tilt their head back with their eyes open, looking upward. Retract the lower lid downward. Invert the medication bottle and gently rest your wrist on the patient's cheek. Gently squeeze the body and instill the prescribed number of drops into the conjunctival sac. Take care not to contaminate the medication dropper or bottle by touching the eye sac or any other foreign objects. Instruct the patient to gently close their eyes. Additional eye drops may be administered 3 to 5 minutes to allow for absorption, so 3 to 5 minutes after the first drops. Application of gentle pressure with a clean tissue on the patient's nasolacrimal duct for 30 to 60 seconds decreases systemic absorption. Glaucoma. So anyone can develop this. It is the leading cause of blindness in the world. Risk factors are African American individuals over the age of 40, anyone over the age of 60, especially Mexican Americans, family history, diabetes, hypothyroidism, patients with myopia, prolonged corticosteroid use, heart disease, and it's more common in women than men. There's several different types. We're going to cover open and closed. So open or primary angle. This is going to be tunnel vision, loss of peripheral vision, mild eye pain. This is gradual. Pathology, so this is more common. It's aqueous humor outflows decrease due to a blockage in the eye drainage system, which causes a gradual rise in intraocular pressure. The normal IOP is 12 to 22, so this is going to be an IOP greater than 22. Closed angle or angle closure glaucoma. So this is rapid onset, decreased vision, severe pain, nausea. They might see colored halos. The patho for this, the IOP is rising and the angle between the iris and sclera suddenly closed, which further increases the IOP. This is an emergency. They need to go in. They probably need surgery. Visual assessment and tonometry. Tonometry measures the IOP, so those are our diagnostics. They are probably, we're also going to get a patient history. Treatment, timolol eye drops. It's usually 1 eye drop in each eye or whatever the affected eye 2 times daily. Laser treatment, surgery in worst cases. We need to monitor for pain, discomfort, decreased vision. We need to educate the patient on different ways to avoid increasing IOP, and also if they need surgery, any surgical education. Some specific post-op instructions for glaucoma patients or any eye care patients. So restriction of strenuous activities. We want them to avoid bending at the waist, lifting heavier objects, anything greater than 25 pounds. They need to avoid constipation for at least 2 weeks. Lifting heavy objects, bending at the waist, strenuous activities, these all increase intraocular pressure, which causes damage to that newly repaired eye. Constipation and straining, that also increases it. It can also increase the risk of post-op bleeding. Any increased pain or drainage is important that they need to call the provider. Any sudden onset of vision loss or worsened vision after surgery, they need to call the provider. That is not expected. All right, macular degeneration. So the macula is a structure in the eye that is located in the center of the retina. The retina converts light and images instantly into electrical impulses and then sends these impulses or nerve signals to the brain via the optic nerve. The light-sensitive cells in the macula slowly start to break down. The dry form of macular degeneration can turn into wet macular degeneration. All people who have wet macular degeneration initially had dry macular degeneration. One of the most common early indications of dry macular degeneration is drusen bodies. These are yellow deposits that are located under the retina, and they're usually found in people over the age of 60. The risk factors for macular degeneration are related to advancing age. Some modifiable risk factors are high blood pressure, high cholesterol, obesity, smoking, and decrease in zinc in the blood levels. In addition to age, family history, gender, and race are other non-modifiable risk factors. So, dry macular degeneration is the most common form of macular degeneration. This occurs when the light-sensitive cells in the macula slowly start to break down. The dry form can turn into wet form. So, there's 3 phases of the dry form. Early dry macular degeneration. This is early, intermediate, and advanced. In early, patients present with a few to small medium-sized drusen bodies. There are no other clinical manifestations and no loss of vision. With intermediate, the patient has medium-sized drusen bodies, or 1 or more large drusen bodies are present on exam. Some patients may see a blurred spot in the center of their visual field. The patient may require more light for reading and other tasks. Patients with advanced dry macular degeneration have a breakdown of light-sensitive cells and supporting tissues in the central retinal area. The presence of drusen bodies is also noted on exam. The breakdown can cause a blurred spot in the center of the vision that will gradually get bigger and darker, taking up much of the central vision. Wet macular degeneration occurs when abnormal blood vessels located behind the retina start to grow under the macula. These new networks of blood vessels are known to be very fragile and often leave blood and fluid. That's where they get their name. The blood and fluid raise the macula from its usual position at the back of the eye, and damage to the macula occurs rapidly. Clinical manifestations of macular degeneration include straight lines that appear distorted, absent or distorted central vision, dark, blurry areas, a whiteout in the center of vision, diminished or changed color perception. Dry macular degeneration causes a gradual blurring of central vision, and the patient may have difficulty recognizing faces. As the condition worsens, a blurred spot may be seen in the center of the visual fields that leads to gradual loss of central vision. Wet causes a quick loss of central vision and is known as the advanced macular degeneration. One of the early symptoms of this disease is the straight lines that begin to appear wavy. Changes in central vision, which is that looking straight ahead vision, along with advanced age, may raise suspicion with the patient's healthcare provider that the patient has macular degeneration. To assess for possible signs of this, the provider completes a comprehensive eye exam, including dilation of the pupils for better assessment of the back portion of the eye. A tonometry exam may also be done to measure the pressure inside the eye. The examination often also includes the use of an Elmsler grid. This exam is done by asking the patient to look at a grid that resembles a checkerboard. The patient covers one eye and stares at the black dot in the center of the grid. While staring at the dot, the patient with macular degeneration may notice that the straight lines appear wavy, or may interpret that some of the lines are missing. A fluorescein angiogram may also be performed for confirmation of wet macular degeneration. This test requires the use of a special dye that's injected intravenously, and images are taken as the dye passes through the vessels within the retina, identifying leaking blood vessels. The 3 most common treatments for macular degeneration are laser surgery, photodynamic therapy, and injections directly into the eye. There's no cure, and despite treatment, the disease and vision may continue to progress. So once dry macular degeneration reaches the advanced form, no form of treatment can prevent vision loss. Let's see. Let's get into all this right now. All right, we're going to move on to cataracts. All right, so cataracts. So these affect nearly 22 million Americans aged 40 and older. By age 80, more than half of all Americans have cataracts, and they are slightly more likely to affect women than men. So what is a cataract? A cataract is a clouding of the eye's crystalline lens. The lens is a clear part of the eye that focuses light on the retina for precise, accurate vision. In the normal eye, the light passes through the crystal clear lens to the retina. The clarity of the lens is necessary for the retina to receive a sharp image. The lens is composed of mostly water and proteins. The specific proteins within the lens is injected directly into the, produce a chemical reaction to maintain the clarity of the lens. Alterations in the lens proteins occur over years as a person ages, yielding a gradual clouding of the lens secondary to chemical change. Other factors resulting in cataract formation include direct blunt trauma to the eye and glaucoma from diabetes. Clinical manifestations of cataracts include clouded, blurred, or dim vision, increasing night vision difficulty, sensitivity to light and glare, halo vision around light sources, fading or yellowing of colors, and double vision in a single eye. The manifestations change and become more dramatic as the cataract grows larger and distorts more of a patient's vision. Risk factors include age, UV light, family history, African American, Hispanics, diabetes, autoimmune disease, obesity, hypertension, smoking and alcohol use, long-term lead exposure. The diagnostics are generally completed on physical exam of the patient and includes a visual acuity test and a direct ophthalmoscope examination with a slit lamp to observe the eye closely. Opaqueness is often readily seen by the provider during the exam. Treatment. The most effective treatment of cataracts is surgical removal of the opaque lens. If surgery is not an option for the patient, regular follow-up with the provider is recommended so that the progression of the condition may be followed and changes to eyeglass contact lens prescriptions may be made as needed to maximize visual acuity. This can be prevented by having the patient wear sunglasses. So we need to administer safety precautions because they have poor vision. We need to maybe have them not be driving. Administer eye drops, so mydriatic, which are dilating, and siloplegic, paralyze the ciliary muscles to keep the eye dilated, are drops that are often prescribed to prep for surgery, for that laser surgery. The removal of the lens surgery. Elevate the head of bed 30 to 45 degrees post-op to help promote drainage, prevent any increased IOP. Position your patient on back or non-operative side to promote drainage and decrease IOP. Maintain eye patch as prescribed by the provider. The eye patch offers protection, minimizes eye movement, and decreases discomfort. Administer stool softeners, increase fiber and fluid intake. String with bowel movements increases IOP. Pre and post-op teaching for the patients having surgical intervention. So the exact pre-op instructions to be obtained from the provider. These could include NPO status, administration of pre-op eye drops, arrangements for a friend or family to drive the patient home after the procedure, different position changes. Again, with the prevention, so that's the wearing sunglasses. So protective eyeglasses worn in the presence of sunlight decrease UV ray damage, and that's a known factor. You want to talk to them about their follow-up appointments. And that's about it on cataracts. So we are going to move into conjunctivitis. Conjunctivitis is a non-specific term used to describe an inflammation of the conjunctiva of the eye, most commonly known as pink eye. This condition is usually caused by a wide range of conditions and is present throughout the world. It affects all ages, races, genders, and socioeconomic status groups. Risk factors for this condition are sporadic or related to the epidemic outbreaks. The condition termed conjunctivitis is described as an inflammation of that conjunctiva. Diagnosis of this is made based on history, clinical presentation, and the most common forms of clinical presentations are related to what it is related to, so to say. So allergic conjunctivitis. So this is secondary to an allergy-causing substance like pollen or dander. So your patient will generally have a red or pink sclera, intense itching, burning, tearing, puffy eyelids. Then there's bacterial conjunctivitis. So this is obviously an infection caused by a microbe or bacteria. This causes a gritty sensation in the eye. Sometimes patients say like they feel like there's sand in their eye. There's often purulent eye discharge and matting of the eyelashes upon awakening in the morning. We see this often with little kids. Viral, so obviously this is related to a virus, seen with common colds, upper respiratory tract infections or sore throats are often accompanying this. So I will have watery discharge, and this often spreads from one eye to the other. Chlamydial conjunctivitis, so this is STD related. This is hand-eye, so someone has chlamydia and they go to the bathroom, whatever, it's on their hand, they touch their eye, and now it's transferred to their eye. So they can have clinical manifestations for weeks or months. This can actually cause blindness. It's actually considered worldwide, and in the past was considered the leading cause of blindness. This can also be transmitted from mom to baby if mom delivers baby while having active chlamydia. So contact lens-related conjunctivitis. So this is a hypersensitivity to one or more of the chemicals used to make the contact lens or the soaking solution. So it leads to that inflammation, and this can also be caused by like a dirty lens or debris under the contact lens. So mechanical, this is irritation related to maybe an eyelash or foreign body, other object. Traumatic, so this can be laceration, abrasion, or chemical injury. This is a secondary response to that. Toxic, so this is related to a corrosive or noxious chemical. I actually had a patient come in when I worked at Baywood ER as a travel nurse. He got the sap from a fire stick plant in his eyes. And we had to irrigate his eyes, but so he had some toxic conjunctivitis because that is corrosive. So the treatment depends on the causative agent. So we're going to take a comprehensive history, trying to figure out what is the cause. We might use, the provider would use a slit lamp or other instruments to verify that there's no foreign body. If it's chlamydia, the provider is going to take a culture for a microscopic examination. Visual acuity checks are performed before and after treatment. Many clinical manifestations are similar, and comprehensive history is essential to making the correct diagnosis. It's a nuisance for most patients who suffer from the condition, but early diagnosis and definitive treatment offer relief and prevent possible transfer of infection from one eye to another or to another person. Most treatments are effective, and the condition is easily resolved in 10 to 14 days. Again, most commonly, if it's that if it's bacteria related, they're going to get those antibiotic eye drops, and they should be good. All right, corneal abrasion. So this is my dog Zara. So speaking of fire stick, previously I had a fire stick in my yard when I moved here, and she was digging, and it actually thankfully did not break, but it poked her eye and she got a corneal abrasion. She is fine, both eyes are fine. If you're my students, you have probably seen plenty of pictures of her by now, and she's doing great. So anywho, so one of the most common eye conditions leading to emergency visits are corneal abrasions. They are estimated to account for 10% of eye-related visits to healthcare providers. Contact lens wearers come in often with these, more often than not. These can be superficial or deep. It's a laceration on the cornea or abrasion. They're defined as a disruption of the cornea resulting from physical or chemical trauma. The abrasion is a disruption of the integrity of the cornea that is limited to only the epithelial layers. These abrasions can be small or large, and they usually heal in 24 to 48 hours of injury. There are the deep ones that kind of penetrate the Bowman's membrane. That's a smooth layer of the eye located just under the epithelium. These take a little bit longer to heal. In your book, I don't have the page number, but it's figure 46.3 has a nice image of that. Most common risk factors for corneal abrasions are going to be our contact lens wearers, participation in contact sports, presence of outdoor and windy conditions without protective eyewear, any abrasive eye injury, dry eye syndrome, abuse of topical eye anesthetics or steroids, autoimmune disorders, and recent eye surgery. The four most common causes are trauma, foreign body, contact lenses, and spontaneous defect. So the common manifestations are going to be eye pain, photophobia, and that's the bright lights. Like, so that's my dog here. She couldn't really open her eyes. I have other pictures with both her eyes squinting because the bright light was really bothering her. So spasm causing squinting, tearing, blurred vision, and sensation of a foreign body in the eye. So medical examination, this is going to be a comprehensive exam by a healthcare provider. The exam includes a visual acuity test, anesthetizing the eye with an anesthetic agent. So usually this is tetracaine, corneal staining with a fluorescein stain, and a visualization under the Woods lamp. So the doctor's going to do that to confirm the diagnosis of the abrasion. It's pretty cool. So when they do the stain, you actually can see like the little abrasion, or if there's a foreign body, you can see it. It's pretty cool to see. Upon confirmation of the diagnosis, they're going to do antibiotic eye drops to help decrease the muscle spasms of the eye patching, but that's actually controversial, so it may or may not be used depending on the provider's thoughts. Tetanus vaccine should be verified if they haven't had it in the last 10 years because they have this open cut, they should probably get it. And then we want to do discharge instructions to wear sunglasses for pain relief and follow up with the eye care professional in 24 to 48 hours after. Most of these are treated medically. If it's extensive, they might need something further. Maybe a surgical repair, but again, that's extensive. Usually this is just treated with eye drops and kind of, resting that eye with sunglasses and trying to, avoiding the sun and whatnot. Retinal detachment. So this is kind of a scary one. So in the US, it's estimated that the incidence is 1 in 15,000 people. The disease is noted to be more common in patients over 40, affects men more than women, and Caucasians more than African Americans. Risk factors are patients who suffer from extreme myopic refraction disturbances, history of a retinal detachment in the other eye, family history, patients who have had cataract surgery, patients who have suffered eye injuries, other eye diseases, disorders, and then diabetes, tumors, sickle cell disease, leukemia, eclampsia, and prematurity. Retinal detachment occurs when there is a separation of the inner layers of the retina from the underlying retinal pigment epithelium, also known as a choroid. Which is also known as a vascular membrane that contains large branch pigment cells located between the retina and the sclera. Separation of the retina from the retinal pigment epithelium occurs following 3 basic mechanisms, and they're kind of hard to say. So regmatogenesis. So this is the most common form of retinal detachment, and it occurs when a tear or break in the retina allows vitreous fluid to move under the retina and separate it from the pigmented cell layer that nourishes the retina. Tractional. So this is the least common type, and this condition occurs when scar tissue on the retina surface contracts and causes the retina to separate. from the retinal pigment epithelium. Exudative, so this form is related to retinal disease, including inflammatory disorders and injury or trauma to the eye. This is related to vitreous fluid leaking under the area of the retina, detaching it. Clinical manifestations, so these can be sudden or gradual. Patient may notice a increase in the number of floaters in the visual field. They might experience light flashes or the appearance of a curtain over their field of vision. Patients may describe painless change in visual acuity and might say that they feel like they're looking through a veil or cobwebs. Immediate evaluation followed by surgical intervention is the only effective treatment for this. The goal is to stop any further progression of vision loss. The damage that occurred cannot be reversed, so we would just want to prevent further damage. They could do laser surgery. That's what's used most often to repair this. And then they have a few other different types, panretinal, photocoagulation, chiropexy. These are some other ones that can be done. We want to loosely cover both eyes. Movement of either eye can exacerbate the internal eye injury. Eyes move together, so we want to, again, cover both. Pre-op instructions, so after evaluation, the patient should be given detailed instructions on the type of intervention that is to be done. So a patient pre-op teaching is important for patient safety as well as first steps to understanding the post-op instruction. Instructions are usually given to a family member or a friend to decrease the chance of misunderstanding. Post-op instructions, so these can differ slightly for each provider, but most include an eye patch, when to leave it on or off and how to change it. Installation of eye drop medications, including the type of medication, the schedule, and how to do it. Monitoring for hemorrhage, notifying the provider immediately for increased pain or drainage from the eye. Prevention of vomiting, sneezing, sudden movement, lifting or constipation, because these all increase IOP, which can cause the detachment to actually worsen. No bending at the waist. Most providers also suggest dark sunglasses in the presence of bright light to prevent further retinal damage. Post-op positioning, so we need them to assume whatever position that is ordered by the provider. So a lot of times this is either being upright or being sideways for a few days. And then obviously administer the stool softeners. Anything that's going to increase IOP, that intraocular pressure, we want to avoid. So we want them to not strain and no bending over, etc. Eye trauma. So blunt trauma can yield injury where bleeding occurs in the front eye between the clear cornea and colored iris. This condition is referred to as hyphema, which is that like the blood in the eye. It can vary in size from microscopic to the total involvement of the eye. Trauma of this nature can also cause damage to the lens, yielding cloudiness or displacement. Damage to the retina causing detachment or tears is also common with this type of injury. So for blunt eye trauma, the most common is going to be motor vehicle accidents, assaults with weapons, and falls, or a periorbital contusion, which is that black eye. That's the most common eye injury. All right, penetrating eye trauma. So this is usually associated with lack of protective eyewear, and this is corneal damage. It could be a laceration, abrasion, globe rupture, which is an ocular emergency that occurs from either blunt or penetrating trauma. And these are often obviously sharp objects causing this. You can Google online. I couldn't post any of the pictures just because they are a bit aggressive, but there's like nail gun to the eye, like different, yeah, I'm not posting that. Medical management. So we want to do rest, eye patching, special eye drops might be prescribed. Antibiotic eye drops are probably going to be prescribed, especially if there's any infection with the eye trauma. We want them to follow up with an eye care specialist, usually pretty frequent, because close observation is essential for the healing. We want them to prevent further damage, including hemorrhage. Patients should present to the provider with the penetrating object in the eye. They should never try to remove it on their own. neither should you. We want the healthcare professional, the doctor, to do that. They're probably going to have a CAT scan and an x-ray done just to observe the extent of any damage. Again, verify that tetanus shot. Eye care follow-up, so patients need to be instructed on compliance with the follow-up exam. Regular exams need to be done for their best chance of retaining sight. Specific instructions, so they need to understand all their post-procedure, post-op, post-medical treatment, including their eye positioning, any eye patch care medications, and activity restrictions. Hearing loss. So 1/3 of Americans between 65 and 75 suffer from hearing loss. Different risk factors are aging, specifically age greater than 60, hereditary, occupational and recreational noises. So this could be gunfire, fireworks, loud music, any different really loud noise. Exposure to certain medications, which we'll talk about a little later. Illnesses including autoimmune disorders and congenital abnormalities. In a normally functioning ear, there are 3 parts that work in harmony to allow hearing and processing of sound. Sound is gathered by the pinna. The waves of sound enter the ear by traveling through the auditory canal until they reach the tympanic membrane. The sound waves set up vibrations into the eardrum, causing middle ear structures to move back and forth. The cochlea then receives the sound vibrations, and finally, the sound stimulus travels to the auditory nerve and the cerebral cortex. So hearing loss can be conductive, sensory neural, or mixed. Conductive is most commonly caused by a lesion in one of the main structures, like the tympanic membrane, the ossicles, or inner ear. A lesion present in one of these structures prevents sound from being conducted into the inner ear. Sensory neural hearing loss is the result of a lesion present in either the inner ear or on the 8th cranial nerve, that neural nerve. Sensory hearing loss is sometimes reversible, whereas a neural hearing loss is permanent. Sensory hearing loss is sometimes reversible, where neuro is permanent. Determining the etiology of the hearing loss is essential in guiding proper treatment. So neural losses can be life-threatening because they often are related to a brain tumor. Mixed loss is a combination of conductive and sensory neural, so it involves both the middle and inner ear. And this type of hearing loss may be caused by severe head trauma, chronic infections, or genetic disorders. In the book, there's a great table. It's 48.1 and it describes the common pathology, signs and symptoms, and the types of hearing loss. So I suggest you go there for more information. I also have this little Venn diagram on here as well that you can take a peek at. So medications that are ototoxic. So these are not limited to, but commonly it's vancomycin, aminoglycosides, cisplatin, acetylsalicylic acid or aspirin, furosemide, and quinine. So those are very common. They cause damage to some of the sensitive structures of the ear, so that's why they're ototoxic. So signs and symptoms or manifestations of hearing loss. So we'll commonly see them turning up the volume on electronics like the TV and radio. They frequently ask people to repeat what they're saying. Withdrawal from conversations, so they don't want to be involved because they have so much trouble hearing. Avoiding social situations in which the patient was once an active participant. Disturbance in the quality of speech, so if your patient's speech isn't as great. Intermittently fighting with spouse or family members over hearing-related issues. So medical management, we got to do our history taking, otoscopic evaluation, and diagnostic testing to determine an accurate diagnosis because we need to know why they have hearing loss. So again, treatment depends on the cause. So if it's an infection, we're going to do antibiotics. They might do tympanoscopy tubes if there's like an issue with fluid. Autoimmune disorders are often treated with corticosteroids and ototoxic medications. They're usually advised to discontinue that medication if a less toxic one is available. So how do we help these patients? So If there's anything operative or surgical, we're going to do our pre-op, post-op instructions. We might position our patient flat, turned on the side if they have an operative side facing up after a tympanoplasty. That's just because of packing. We need to have them make appointments for hearing evaluations. If they have like dried serum impacting their hearing, we're going to increase fluids. We want to make sure that they'll be compliant with any pre-op or post-op teaching. So pre-op, there can be transient hearing loss immediately after surgery because of the packing placed into the ear. We want them to avoid forceful coughing because this places increased pressure on that middle ear. We need to keep that ear dressing dry to decrease the risk of infection, and all ear dressings are performed using sterile technique. We want to make sure our patients are educated on noise protection. So this could be earplugs, earbuds and earphones are discouraged because they're very loud and they're entering right into that ear canal. So we want to recommend like earplugs or like headphones that are like noise canceling for these patients, especially if they're, someone that's going to the gun range or something like that, or around loud music, they're a DJ, they should have headphones to help cancel some of that noise. We need our patients to avoid using cotton swabs or any devices that remove earwax. These can cause damage to the tympanic membrane, and they also really push earwax deeper into the ear. And then also, obviously, if they have any surgery or anything, we always want to coordinate and help them with their follow-up care. External otitis, also known as swimmer's ear. This is common all over. It's more common in ages 7 to 12 because they're in warm water, doing water sports. Again, swimmer's ear. So different risk factors: warm temperature climates, high humidity climates, history of swimming, hearing aid use, recent trauma to that ear. Clinical manifestations, so usually there's swelling visualized in and around the external ear. The external ear might be tender to touch. There's pain on movement or pressure to that outer auricle of the ear. Or you can actually see erythema or edema in the ear canal. There could be scant clear drainage from that canal. So the treatment for swimmer's ear or external otitis, we're going to clean that ear canal, treat the inflammation and infection. So this could be your antibiotic ear drops, or even topical antibiotics sometimes are good for this on the external ear. Inflammation we could treat with NSAIDs like ibuprofen. The pain we could treat with Tylenol or ibuprofen. And again, for this, we usually prefer topical antibiotics versus oral for this ear infection. More information on this can be found in your F.A. Davis textbook. All right, otitis media. So this is going to be that inner ear infection. This is usually seen secondary to a viral upper respiratory infection. So normally, middle ear mucosa absorbs air in the middle ear. When someone has otitis media, they have inflammation and secretions that are causing an obstruction of the eustachian tube. So if that air is unable to infiltrate the eustachian tube, it can cause an obstruction, or because there is an obstruction, a negative pressure is created that then pulls interstitial fluid into that eustachian tube, and then it creates a serous effusion. The serous effusion provides that perfect medium for microbial growth in that middle ear. Rapid growth of the bacteria becomes overwhelming and yields a middle ear infection, also known as otitis media. So this can affect anyone, but it's more common in children because the eustachian tube is flatter. Different congenital issues, again, if there's an upper respiratory infection, seasonal allergies. So common symptoms. So this patient's going to have ear pain. Little kids might be tugging or pulling at their ears. Little kids, infants, they might refuse to feed because the sucking actually increases that ear pain. Someone can have trouble sleeping or lying flat because it hurts their ear. Fever, in younger kids, it's usually a higher fever. For adults, it's more low grade. Fluid or blood draining from the ears, especially with the tympanic membrane rupture, which is what we really want to avoid. They also might complain of hearing loss because if they have all that inflammation, their hearing might be muffled. So diagnostics for this, we want to take a good history and then also an otoscopic evaluation to take a look at those inner structures. So for an inner ear infection, we're going to treat with oral antibiotics. If there is a tympanic rupture, then they're going to add on antibiotic ear drops. Obviously, we want to treat the pain. This could be NSAIDs, Tylenol, and then same thing for your antipyretic will be the same idea, Tylenol, or you could do ibuprofen. So for chronic, they might do a tympanocentesis or a laryngotomy. You can look into your book if you want to know more onto those. And then complications are going to be chronic suppurative otitis media, cranial nerve, 7 paralysis, labyrinthitis, labyrinth fistula, mastoiditis, petrocytitis, and meningitis. So again, management. Sorry, just give me 1 second. Where am I? Surgical management. So sometimes this is considered for the chronic. Let me see if there's anything I want to add. Okay, so for teaching, we're going to work on antibiotic therapy. Make sure your patient knows what they're taking, how to take it, to continue even if they feel better. We need them to complete their antibiotics. Medication instructions, they need to avoid getting any water into the ear because it will increase the risk and worsen the infection. It also will increase pressure and pain. And always we want to tell them about the follow-up care because that's always key to determining if the infection resolved. Tinnitus. So this is commonly called as ringing in the ears. So this is a clinical manifestation. It's not a disease. To the right of the slide, you can see different reasons that tinnitus might happen. This is from your F.A. Davis book. So risk factors for tinnitus are going to be advanced age, loud noise exposure, earwax blockage, genetics, medications. So again, with the ringing in the ears, it could be buzzing, roaring, clicking, whistling, hissing. I've heard whooshing. And this can be consistent or intermittent. We want to treat the underlying cause. We want the patient to consider keeping a diary because if we don't know the cause, if they keep a diary, we might be able to pinpoint what it is. Again, we're going to treat that underlying cause, but medications frequently prescribed are going to be alprazolam, anticonvulsants, antihistamines, acamprosate, niacin, gabapentin, and tricyclic antidepressant. Vertigo. So this is that like spinning, feeling like you're motion sickness. That's kind of your vertigo. So risk factors, different medications, head injury, upper respiratory infection, cerebral vascular disease, advanced age, a family history, Meniere's disease, labyrinthitis, and migraines. So again, these patients feel that spinning sensation at rest or with minimal movement. They feel imbalanced, they feel lightheaded, nausea, vomiting, they can have hearing loss. It's just very uncomfortable. So for this, we want to treat the underlying cause. Again, with treating the underlying cause, common medications used to treat this are diazepam, meclizine, prochlorperazine, scopolamine, and glycopyrrolate. We want to teach our patient to decrease their intake of salt, nicotine, alcohol, and aspartame in their diet. We want them to reduce stress. So some safety considerations with these patients. So if they have a loss of balance, they're high risk for falls. So we want to ensure that the environment's clutter-free. If they need an assistive device like a cane or a walker, that they have it to just kind of help steady them. We should tell them to minimize frequency and position of changes because patients with vertigo can benefit from limiting their position changes because that helps decrease the feeling of dizziness. So with the limiting for food, so limiting salt intake is particularly important in this patient, especially if they have hypertension. Avoiding caffeine is important because they should avoid the stimulant effect, and aspartame can have toxic effect on that inner ear and brain. The idea of reducing stress is to decrease CNS excitability and therefore decrease the clinical manifestations. Some complementary and alternative therapies are ginkgo biloba and ginger ale. And ginger. Those are possible remedies in treating clinical manifestations, but there's no real explanation as to why those substances work in decreasing the vertigo. Meniere's disease. So the exact cause is unknown. There are several correlations that have been made about this disease. It's known to occur most common with infections during periods of high stress, after a traumatic injury, and with allergens. Clinical presentations are a clinical triad of vertigo, tinnitus, and hearing loss. These patients also exhibit an excess of endolymphatic fluid, which is lymph fluid within the ear, in the inner canals of the ear. This causes an obstruction of the inner canal system and leads to distension of this portion of the inner ear. This disruption leads to vertigo because of the damage to the vestibular system. Decreased hearing from the dilation of the cochlear duct that stimulates development of tinnitus is also observed in patients with Meniere's disease. This affects 615,000 people in the US, and they say that there's more than 45,000 new cases diagnosed each year. The peak age for this is 40 to 60, and females are affected more than males. Normally, patients come for healthcare treatment when they have that tinnitus, vertigo, and hearing loss with no specific cause. Some risk factors are going to be head injury, middle ear infection, syphilis, allergies, alcohol abuse, fatigue, respiratory infection, history of a recent viral illness, smoking, and certain medications. So with the clinical manifestations, so obviously we have that vertigo, tinnitus, and hearing loss. Additionally, they can have nausea and vomiting, sweating, unilateral and sometimes bilateral for that hearing loss, diarrhea, headaches, abdominal pain, uncontrollable eye movements like nystagmus. And those clinical manifestations often increase the sudden movements. So there's no cure for this. Diagnosis is based on clinical presentation after ruling out other disorders. Treatments aimed at providing symptomatic relief. So different medications, dietary changes like low sodium diets. We might have them decrease fluid. Because they're thinking that fluid, if we decrease fluid, it will decrease the fluid present in the semicircle canals of the ear and therefore relieve pressure of the inner ear. We're going to do a Romberg's test, which is a balance test. So again, supportive measures for this. So low sodium diet, avoiding sudden movements, avoid bright lights, ensure at least 8 hours of sleep per night, acupuncture, and regular daily exercise. Limit caffeine, limit alcohol. Some surgical interventions that can be considered if it's severe. A vestibular nerve transection. This helps control vertigo without damaging hearing. They might surgically instill gentamicin directly into the middle ear. This can help decrease vertigo symptoms in some patients. A radical surgery reserved for very severe cases includes removal of part of the inner ear called a labyrinthectomy. This surgery improves the clinical manifestations of vertigo, complete hearing loss in the inner ear, and affected side is a result of the procedure. So they will have complete hearing loss on the affected side if they have the labyrinthectomy. So teaching. So we want to teach the patient about the disease process, any testing, pre and post testing that they're going to have, the teaching the family and patient about this can help decrease anxiety. Any medications that they're going to be put on, safety, if they have balance, if they have vertigo, they may have balance issues, so we want to consider a cane or walker. Any follow-up care, we need to make sure that the appointments are made or the patient has understanding of what appointments need to be made. All right, moving from hearing to integumentary. So we have bacterial skin infections. So most skin infections are gram-positive bacteria like Staphylococcus aureus or Streptococcus pyogenesis. We also obviously have our MRSA, which is the methicillin-resistant Staphylococcus aureus, and this could be community-acquired or hospital-acquired. So we have necrotizing and non-necrotizing. So with bacterial skin infections, we're going to kind of talk about cellulitis. So non-necrotizing cellulitis occurs when microorganisms, especially streptococcal and staphylococcal species, find a portal of entry through breaches in skin integrity. Initial presentation can include erythema, warmth, edema, and localized pain. Cellulitis is identified by rapidly spreading erythema, warmth, localized pain, and edema with possible inflammation of regional lymph nodes. So that's when it's spreading, that's pretty bad. Necrotizing soft tissue infections are very serious, they can be life-threatening, and they spread rapidly and destroy a significant amount of tissue. They can penetrate and spread through the dermis, subcutaneous tissues, fascia, and muscle. Necrotizing infections include fascia are more common because of the fascia's poor blood supply and limited immune function. This allows pathogens to spread rapidly along the facial plane. Initially, systemic manifestations of necrotizing soft tissue may be mild, but if they're left untreated, they're going to be fever, tachycardia, pain disproportionate to physical findings, disorientation, lethargy, and hypotension. A systemic infection, meaning that they're becoming septic if they're not already. In necrotizing fasciitis, palpation of the erythema skin can yield firmness to the underlying tissues. Eventually, these lead to edema and vascular occlusion that causes ischemia, tissue necrosis, with resulting loss of feeling of the involved area, and sepsis. The most common sites for this are the abdomen, lower extremities, and perineum. Fournier's gangrene is a descriptive name given to necrotizing fasciitis in genital or perineal area. So necrotizing means that it's literally killing. So necrotic tissue is dead tissue. So if it's necrotizing, it is killing the tissue. So patients who present with systemic manifestations of infection require an aggressive approach to management. So initially, the diagnostic is going to be a blood culture and sensitivity, complete blood count with differential, serum electrolytes, and C-reactive protein to monitor for inflammation and effects of treatment. Marked abnormalities of these results, accompanied by hypotension, require immediate hospitalization for fluid resuscitation, surgical evaluation, and initiation of broad-spectrum antibiotics. So we're going to get culture and sensitivity. We're going to draw these blood, but we also are probably going to swab the wound as well. And then, so initially, we're going to start the patient on broad-spectrum antibiotics. Once we have that result of the culture with the sensitivity, we're going to put them on a more specific antibiotic. So obviously complication of this with the antibiotics is if we're just prescribing everyone broad spectrum antibiotics, we're going to misuse them, and that's when you get your resistant antibiotics. With a non-necrotizing, a potential complication is that it becomes necrotizing. Treatments, again, antibiotics. We're going to do wound care for these patients, and then we're going to also do a surgical evaluation. The nasal swab is on there because we are going to swab their nose for MRSA. And that about sums up our bacterial infections. It's going to be cellulitis, whether it's necrotizing or not. HSV, herpes simplex virus. So this is, it's on the skin, mucous membranes. central nervous system, genital tract are where this is seen. Often, this is somebody who just gets like a cold sore. There is a primary and a secondary infection for this. So your primary is going to be that first time the individual's infected. So they are either getting this from direct contact with an individual who is asymptomatic, or that individual can be in the prodromal stage of the disease, or they can have an active or genital infection, secretions, lesions. So they're getting it from somebody who has the virus, whether they show symptoms or not. So now this person has contracted it, and once you have it, you have it. There's no cure. So then the secondary is that recurrent HSV. So these people, it could be, so the virus is dormant, and then they're exposed to the sun or UV light, and they have a cold sore breakout on their lip. Febrile illness, high stress, these are all different things that can trigger an outbreak. Some people get just one cold sore, some people get multiple, and again, it can be any of those areas that are listed at that first bullet point. Usually before the symptoms come, there is a prodrome, and this could be someone has tingling on their lip, and then a day later the cold sore comes. So it's kind of like that. It's in the formation stage, and this again could be tingling, it can be burning or itching, and that's where that lesion is usually going to occur. First, an area of redness will appear. This could again be lips, genitals, and then in about 2 days, the appearance of fluid-filled vesicles, whether it's one or more, will come out. So clinical manifestations. So the primary infection usually occur within 2 weeks of the transmission. And a lot of times this is fever, malaise, myalgias, anorexia, irritability, cervical or inguinal lymphadenopathy, or lesions, whether it's lip, face, mucous membranes, mouth, pharynx, genitals. Many times the primary infection is asymptomatic and can be transmitted unknowingly. So someone can have a full-blown primary infection where they have a fever and they have these blisters or vesicles, or they can contract it and have the primary and be asymptomatic and have no idea that they have it. The virus travels down the peripheral sensory neurons to the ganglion, and it remains dormant until a trigger incites an active lesion. So some people have HSV, like they get tested for it, and they never ever show symptoms. So let's see. We'll do virological testing for this. So usually a blood test can show if a patient has it. There is HSV1 and HSV2. So they need to figure out which one it is. Let's see. We'll talk more about herpes as an STI later in the semester when we talk about GU repro, but this is not the same as that. It's a different form. Let's see. So diagnostics, clinical presentation, we're going to do the virological testing. They're going to figure out the specific HSV this is. There's no cure again. I think I said that earlier. We're going to do systemic antiviral therapy. So this person would be given a cyclovir. A lot of times people with cold sores, they just kind of wait it out, or I know some people use that over-the-counter Abreva. And then if somebody has a lot of outbreaks of this, they might go on suppressive therapy, which is typically a low dose of cyclovir. So complications, so this could be psychosocial stress. So if someone's got a bunch of cold sores on their lips, it could make them feel stressed out. They might be embarrassed. We don't mask anymore, so it can definitely increase embarrassment. No reason for it, but again, psychosocial stress. Risk factors for HIV acquisition. So just because you have HSV does not mean that you're going to get HIV. They just, it kind of can go hand in hand a little bit. Disseminated neonatal herpes. So if somebody does have this down on their genitals and they deliver their baby, the baby can get this. Patient teaching. So we need to teach them the role of those antivirals. safe sex practices, pregnancy considerations. If they have an active cold sore, maybe don't go kissing your partner because you're going to spread it if they don't already have it. Don't be kissing your baby with a cold sore, that kind of stuff. All right, fungal skin infections. So dermaphytes, which reproduce by the formation of spores, cause superficial cutaneous fungal infections. They do not spread beyond the epidermis. Found in living soil, on animals, and on humans, dermaphytes are aerobic fungi that feed on the dead keratin of the skin, hair, and nails. Areas that are occluded, such as toe spaces, are at most risk for infection, and an identifiable characteristic of a dermaphyte is an active raised border. Yeast, on the other hand, multiply by budding and thrive in warm, moist environments on the skin and mucous membranes of the GI tract and vagina. Fungal infections may present as scaling rashes, plaques, vesicles, or pustules. So the diagnostic is usually made with a focus history, physical examination, and microscopy, potassium hydroxide microscopy. Sometimes they'll use a Wood's lamp for exam, a fungal culture, a histological tissue eval. These are just different ways that they can diagnose this. Give me one second, I'm a little lost here. Okay. So antifungal agents are the primary agents used to treat these fungal infections. So healthcare providers often prescribe ineffective antifungal therapies because they don't have the knowledge and incorrectly diagnose it. Not every antifungal medication is the same, so the appropriate treatment for one fungal infection might be different than a different fungal infection. So we need to make sure that we get the proper diagnosis so that we can better manage the disease. So complications of this more so affect patients that are critically ill or immunocompromised. With those really sick patients or patients with weakened immune systems, the candida or the fungus can actually become invasive and it has a high mortality. So we need to be careful with that. So to help prevent this, meticulous hand washing before and after patient contact. Make sure that we're doing cultures. If culture is ordered, we want to get that so we can do the proper antifungal. Obviously, administer the antifungal medications as prescribed. The patient needs to know if they go home on them, even if the symptoms go away, they need to continue. Cleanse incontinent episodes as soon as they occur. Try to keep the area dry. Clean and dry is the best. We don't want that moisture there because it gives that perfect medium for it to grow. The skin folds. Some people get the fungal or yeast in their skin folds, so we want to make sure that we keep those dry. You can even separate them with gauze or other dressings to help keep them dry. The one that is in between the skins is called intertrigo. So that's that soft white skin secondary to the constant exposure to moisture. So again, meticulously cleanliness and application of that antifungal medication. Teaching, they should avoid tight-fitting clothes, shoes, communal washing. If they do have to communal wash, wear shower shoes. Clinical manifestations, so patients need to understand what they can be. And complete antifungal medication that's prescribed, as I already said. On the picture to the right, so that's an image from The Last of Us. That's a cordyceps, which is a type of fungal infection. Has not spread to humans. It's an ant, so we don't have to worry about that yet. But if you know, you know. Psoriasis is an immune disorder that causes chronic inflammation of the skin. It's characterized by thick, raised red patches covered with silvery flaking scales. There are a few different forms. There's plaque, gutate, and erythrodermic. The most common is that plaque psoriasis affects approximately 80 to 90% of those with the disease. Psoriasis is not always limited to the skin. It could be psoriatic arthritis. That is a common manifestation of psoriasis. They think that there might be a genetic component to that, but it's not 100% fact. It's more so in science right now that they're looking that up. There's no lab test specific. It's usually diagnosed based on the symptoms. Some forms of psoriasis can actually mimic other skin disorders like a bacterial or fungal infection. So it's plaque psoriasis. They're most often seen on the elbows, knees, legs, palms, soles of the feet, scalp, trunk, and face. There's no cure for this. So you want to try to reduce the clinical manifestations, control the disease, improve quality of life. We'll give them topical creams, topical steroids for this. There are some UV light therapies that they can do. So we want to teach these patients side effects of medications. Patients with psoriasis are high risk for developing other diseases. For example, cardiovascular disease, metabolic syndrome, liver disease, diabetes. It's important to understand the patient's risk for developing any of these comorbidities when teaching them about the different therapies. Looks like there's a lot of research being done. So research suggests that there's a risk of malignancy with these patients. They're at greater risk for developing cardiovascular disease. This can have a lasting or significant impact on the patient's quality of life because this, again, it can be on your face, it can be anywhere. So this will affect the person's physical appearance. So we want to make sure that we're taking into account the psychosocial components of this disease. Skin trauma. So this is anything that's kind of breaching the homeostasis of the skin. So we have, let's see, so the three functions of the skin, let's go by that, are the protection from bacterial invasion and external elements, perception of the environment through the senses of touch, pain, temperature, and pressure, and retention of water through absorption, thermoregulation, immune surveillance, and metabolism of vitamin D. So when the skin surface is breached, the homeostasis is disturbed and skin function becomes less effective. Aging has a huge impact on wound healing. So our types, so we're gonna have laceration. So this is a break in the skin caused by penetration of a sharp object or high shearing force that exert a diagonal force on the skin, causing damage. The edges of the abrasion can be smooth or jagged. Lacerations are superficial, or they can extend deeper into the tissues, and they can affect nerves, muscle, bone, or tendon. Lacerations that are superficial and do not involve the underlying tissues are usually treated by the primary healthcare provider's office. Abrasions, so these occur as a result of friction and shear from external forces. They're usually minor, involving only the epidermis. Some involve part or all of the dermis. An example would be grazing or scraping injury to the skin or knee of a patient who fell on concrete. Minor abrasions do not usually require treatment by a healthcare personnel, leading to difficulty in determining incidence and prevalence rate because these injuries are not consistently reported. I mean, how many of us have had abrasions? You don't go to the doctor over it typically. Excoriation. So this is superficial abrasion. It can be self-induced through repetitive scratching and is usually linear in appearance. These are commonly seen in disorders of the skin that cause itching, so insect bites, scabies, dermatitis, and chickenpox. The term excoriation is also used to describe the loss of epithelium in response to prolonged exposure to urine and feces in an individual who is incontinent. Urine and feces alter the pH of the skin, causing it to become more alkaline, which supports bacterial proliferation, leading to skin breakdown in the perineal area, also known as incontinence-associated dermatitis. That's the other name for that. Friction blisters. So I think we've all probably had one of those on our foot at some point. So this can be from long-distance runners, sometimes wearing heels, things that cause that friction. It's applied parallel to the surface, results in a rubbing motion. It causes cells of the epidermis to separate, and increased hydrostatic pressure causes plasma-like fluid to accumulate between the cells. So moisture on the surface increases the risk of blistering. This is most commonly on the feet and the hands. Skin tears. So these are traumatic wounds usually caused by minor trauma that primarily affect older adults. This could be wheelchair, different wheelchair injuries, bumping into objects, transfers, falls, tape removal. Be careful with the tape removal on our elderly. So specific assessments for these patients. So we're going to look at their overall health, nutritional status, their skin integrity, mobility, hydration status. We want to look and document the characteristics of the actual area of the skin trauma as well as the surrounding tissue. We want to look at the color, the temperature, if there's any edema, erythema. We want to look at that wound area to assess that perfusion. Look for any signs of drainage. We want to know our different characteristics of drainage. If it's a severe traumatic skin injury, they might need surgery. Generally, we can just perform wound care. So we do this as prescribed. It's usually cleansing and appropriate dressing. So we're going to cleanse the area to decrease the bacterial burden, and moist wound healing products support adequate healing. We will be working on wound care in lab as well. We want to administer pain meds. So for one, if their wound is just painful, we want to give them something for pain. But if you're going to do a dressing change, you probably want to pre-medicate. That's kind of the right thing to do. If it's antibiotic or bacterial related, or we're concerned for bacteria, they might administer antibiotics. Patient might need to be referred to a nutritionist, vascular evaluation if there's decreased perfusion. Depending where the wound is, we might need to provide emotional support. For teaching, we want to teach proper positioning, keep the head of the bed less than 30 degrees to decrease the risk of friction and shear. Older adults are more prone to the effects of friction and shear because of the flattened dermal epidermal junction. If they're incontinent, we want to cleanse that as soon as possible, use moisture barrier creams, try to keep that skin clean and dry. Minimize objects on the floor, maintain the bed on the lowest position. We want to minimize any risk of falling, because that will result in a skin injury or some kind of trauma. Again, importance of nutrition. We want to increase their protein intake. Sometimes wounds require additional nutrition to heal, especially that protein. If they need mobility aids like a cane or walker, or we want to stress them using a claw bell before they walk to minimize falls. All right, so pressure injuries. So this is usually factors of pressure and shear. So pressure is exerted when the tissue is compressed between the surface of which the patient lies and the bony prominence of the body. This causes a decrease in capillary blood flow, leading to decreased perfusion of the localized area, potentiating tissue ischemia, and death. So risk factors for this are going to be obviously impaired or decreased mobility, decreased functional status with exposure to forces of pressure and shear. Our elderly, so increased age, end-stage renal disease, anemia, diabetes, use of steroids, impaired blood flow like with atherosclerosis or lower extremity peripheral artery disease, cognitive impairment, urinary or fecal incontinence, and malnutrition. Also, deficits in hydration can cause this or lead to this. Big risk is a history of a previous pressure injury because the strength of scars over healed pressure injuries is diminished, so they're prone to that repeated breakdown. Terminal illness is another thing. So obviously infection is our major complication of this, so that's what we really want to avoid. So for diagnostic, we're going to look at the wound staging. We'll talk more about that in a few minutes. We might need to get a culture of that to check for any bacteria, CAT scan and MRI might be needed to see if there's any bone or ligament or anything involved other than just the skin. Treatment, we're going to do wound care, usually wet to dry dressings. We usually want to cleanse it prior. If it's really bad, they might need surgical, they might need debridement. Prevention, so we want to decrease pressure to those bony prominences. So we want to turn, reposition every 2 hours. You can use pillows. Adequate nutrition, remember that protein. Utilize draw sheets, this helps prevent shearing, but also try not to have a million sheets and blankets underneath your patient, because that also increases the risk, because you have all these sheets and stuff, which can actually increase more pressure and more shearing. So just try to have one draw sheet underneath the patient, so you can use that to pull them up and down rather than dragging them on the bed. All right, so looking at our different staging. Let me flip my pages. If I can, there we go. All right, so stage 1. So a stage 1, this is intact skin with a localized area of non-blanchable erythema. This may appear differently in darker pigmented skin. So it's presence of blanchable erythema or changes in sensation, temperature, or firmness. Color changes do not include purple or maroon discoloration. These may indicate a deep tissue. So this is usually non-blanchable erythema, so non-blanchable redness. So I push on this and it stays red. That's what non-blanchable means. So then our stage 2 is going to be partial thickness skin loss with exposed dermis. The partial thickness loss of skin with exposed dermis. The wound bed is viable, pink or red, and moisture may also be present as an intact or rupture serum-filled blister. Adipose, which is fat tissue, and deeper tissues are not visible. These injuries commonly result from adverse microclimate and shear in the skin over the pelvis and shear in the heel. This stage should not be used to describe moisture-associated skin damage. Stage 3. So stage 3, this is full thickness skin loss. So this is going to be adipose, or your fat tissues visible in the ulcer, and granulation tissue and epibole, which is like that rolled edge, are often present. You might see slough or eschar. So slough is going to be like that white dead skin cells. Eschar is going to be more black. The depth of the tissue damage varies by anatomical location, areas of significant adiposity, or where there's a lot of fat tissue, that can develop deep wounds. Undermining and tunneling may occur. And then we have our stage 4, which is full thickness skin and tissue loss. So this has exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone. So this one's deep. We're seeing structure and stuff underneath it. Slough or eschar may be visible. Epibole, again with those rolled edges. Undermining, tunneling. Undermining, it's almost like a shelf, and I'll show you guys on the wound butts that we have. I'll show you guys what that is. Tunneling is a tunnel. The depth varies by anatomical location. If slough or eschar obscures the extent of tissue loss, this would be an unstageable pressure injury, which we will look at in a second. So here we have our unstageable. So this is obscured full thickness skin and tissue loss. So the extent of the tissue damage within the ulcer cannot be confirmed because it's obscured by a slough or eschar. If slough or eschar is removed, a stage 3 or stage 4 pressure will be revealed. So stable eschar, which is dry, adherent, intact without erythema or fluctuance. On the heel, that's the most common spot, and you can see it there on the heel. Or ischemic limb should not be softened or removed. So we actually like to keep this intact so that the body can do its job of healing. Deep tissue pressure injury, or a DTI or DTPI. So this is persistent, non-blanchable, deep red, maroon, or purple discoloration. So it's intact or non-intact skin with localized area of persistent, non-blanchable, deep red, maroon, purple discoloration, or epidermal separation revealing a dark wound bed or blood-filled blister. Pain and temperature change often precede skin color changes. Discoloration may appear differently in darkly pigmented skin. This injury results from intense and/or prolonged pressure and shear forces at a bone-muscle interface. The wounds may evolve rapidly to reveal the actual extent of tissue injury and may resolve without tissue loss. If necrotic, subcutaneous tissue, granulation tissue, fascia, muscle, or other underlying structures are visible, this indicates a full thickness pressure injury. Do not use DTPI to describe a vascular, traumatic, neuropathic, or dermatological condition. All right, so granulation tissue. So here's a picture of that. So it's red, pink, it's moist granular tissue composed of new blood vessels, healthy healing tissue. So granulation is good. Hypergranulation tissue. So this is hyperplasia of granulation tissue, and it's recognized by its friable red appearance. This is usually in response to a prolonged inflammatory phase. Necrotic tissue. So this is dead or avascular, meaning it doesn't have blood, or devitalized tissue. Eschar. So this is thick, leathery, devitalized tissue. It can be black or brown, hard, soft, boggy, loose, or firmly attached to the wound bed. Then we have slough. So slough is moist, devitalized tissue. So it's dead tissue. It's white, yellow, tan, green. It could be loose, often stringy. Macerated, so this is that moisture. So it's softened tissue in response to prolonged exposure to moisture. Here's an image for the types of exudate or drainage. So this is in response to wound tissue damage, and these are the most common. So we have serous. So serous drainage is clear, thin, and a watery fluid. Serosanguinous is thin and watery with light red or pink hue. So this is a mix of serous and sanguinous. Then we get to our sanguinous, which is just our blood. So this is bright red, it's fresh blood, it could be hemorrhagic. Purulent, this is going to be like that odorous, thick, yellow, it could be green, gray, it's yucky, it's opaque, and this is from infection. So this is not a good drainage. We do not want purulent drainage. This is also known as pus too. All right. Skin cancer. So, non-melanoma skin cancers are the basal cell and the squamous cell. Let's see. So pathophysiology for skin cancer. So we have UV rays, they penetrate the skin, indirect damage that disrupts cellular membrane, or development of cancerous cells. Treatment, so often we do surgical excision, or they might do a topical therapy for the skin. Our patient teaching, so it's going to be limiting sun exposure, using sunscreen, self-exam, post-op wound care. So I want to I guess let's go over that on the next slide, because I actually have a slide with that. So descriptions. I just want to go over the basic descriptions of basal cell, squamous cell carcinoma, and melanoma. So basal cell carcinoma. So this is the center picture on the bottom. So this is commonly described as having a waxy border, a red papule with a central crater. Our squamous cell carcinoma, seen on the left, is usually crusted papules and plaques that can become indurated and ulcerated. Larger lesions can become painful and bleed. Melanoma, which is seen on the right, has varied color and irregular shape, and it can be raised or crusty in texture. So we want to provide emotional support to these patients, to the client and the family. We want to teach them about limiting sun exposure, sunscreen use, self-skin examinations, wound care if they have a post-op excision, information on different types of the skin cancer, and again, provide them with the support. The American Cancer Society has a group for the diagnosis of skin cancer. Next, we're going to talk about the different things to look for on that self-exam. So for skin cancer, we do A, B, C, D, E. So A is asymmetry. So we're looking at the mole. Is it asymmetric? Is one side not matching the other? That's kind of what we're looking at. Border. Is the border irregular? So as you can see on this picture, what an irregular border looks like. Color. So is there a color variation on the mole? Diameter. Is it greater than 0.25 inches or 6 millimeters? Evolving. So is it evolving? Is it enlarging? Is it changing? Is something changing on it? Are they getting more? That's what we kind of want to look at, or, you know, having any kind of change in the shape or color. Here's more pictures of the different types. So our basal cell, squamous cell, and melanoma. I'm not going to repeat the descriptions. Reconstructive surgeries. So this is the closure of a wound by a plastic surgeon. Usually there's minimal scarring. Most often these are cancer reconstructive surgeries, tumor removal repair. There could be scar revision, laceration repair, dog bite repair, hand surgery, breast reconstruction, microsurgery, burn care, all different types. It's either cosmetic or reconstructive. So medical management of the post-op usually involves assessment skills. So that's where we're looking at it. We might be running labs. We're going to be looking at that surgical site for any signs of infection, monitor if they have a skin graft, any free tissue transfers. We want to look for erythema, increased warmth, purulent drainage. We want to make sure that the approximation is in line. We want a nice incision line. We want to watch for swelling, pain, and any local swelling. Obviously, we're going to be administering pain meds as needed, and we want to teach our patients about if they need to follow any specific diet. We want to teach them about those signs of infections, what we expect for healing, any wound care that needs to be done, or if we need to do wound care, we need to do it per order, and appropriate methods of offloading. This could be, it really depends what type, but how they should offload and stand up depending on where their incision is. Repositioning while lying down. They should make sure that they move every 2 hours to help diminish any effects of pressure. And that about sums this up. I know this is a long one, but I appreciate you all for sticking with me and staying through it, and I am excited to see you in class.